We are the Center for Advancing Health Outcomes, research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Good afternoon, everyone. Welcome to the Advancing Health Talks, the Work in Progress seminar series. And it's my pleasure to introduce Dr. Nadia Khan, who's a professor and head of the General Internal Medicine Division and professor of medicine at the University of British Columbia. She's a clinician scientist in health services research and epidemiology, I can't speak today, at the Center for Advancing Health Outcomes, which is located in Vancouver. Her research area includes marginalized groups, including ethnic and gender impacts of cardiovascular disease risk factors, health service utilization, and cardiovascular disease management. She's also working at Providence Healthcare as a physician lead for improving physician wellness through systems change initiative. And we're looking forward to hearing about this work. So thank you, Nadia, for presenting. It's been wonderful to have you as a colleague over the years, and I look forward to hearing this talk.
Thank you very much, Dr. Palapu, for that warm introduction, and good afternoon, everyone. We'll start with a land acknowledgement. We work and do research and see patients all on the land of the Coast Salish peoples. That includes the Squamish, the Stalo, the Tsleil-Waututh, and the Musqueam nations. As Dr. Palapu read out my research biography, it's really more in the lines of big data research and looking at marginalized populations. So this was actually a fairly significant departure for me for research. And it really highlighted, and the reason why I titled it as Pragmatic Research from Within, is I, for the first time, got to experience what it's like also being a person with lived experience when people are doing research. So I had this unique vantage point, and I hope to share some of the work that we've done and the insights that we may draw from this. And then the other thing was that you may have heard, but the WHO released just about 3 months ago a clinical practice guideline, or a guideline on best practices for clinical trials. And there they really emphasize use of more pragmatic research or pragmatic research elements. So I thought that this would be a great opportunity for me to present this work that I'm doing, which is really a passion project that has sort of morphed into more research. And just to start with pragmatic versus explanatory research, and really pragmatic research and explanatory research, which we think of more traditional research, is on a continuum. We have on the one end the classic clinical trials that we're very familiar with, the classic types of research, where we have a significant control group, we have an intervention, we have a lot of fidelity and adherence to that intervention, we have inclusion criteria, recruitment, et cetera. So that's the research I think that we are all very familiar with. And on the other end of the spectrum is pragmatic research. And pragmatic research is more of open recruitment, a lot of flexibility with recruitment. Interventions are created by participants, patient-oriented work. The interventions are more flexible, so they are not necessarily adhered to in pragmatic research. Primary outcomes, you are hoping that they're more patient-centered, and then the primary analysis would take this into account. Now, of course, research is not always on the extremes of these two endpoints, and many trials have some pragmatic elements and some explanatory elements. So I think the research that I'm going to show you, a case study, is much more on the pragmatic side. So we'll get started. So today, in this next 50 or so minutes, through this case study, will understand issues of physician burnout. And again, that's also on a spectrum with wellness on the other end of this, and discuss the research findings that we did right here in our own local Providence Healthcare on physician wellness, and how we use mixed methods approach to try to gain an understanding of how is it impacting us, what are some of the factors that are local that are driving this, and then our next step, which was a pilot study, more evaluative, quasi-experimental study on organizational change. And then I want to bring back this pragmatic learning health system research approach and understand what are some of the limitations and benefits that I've experienced through this sort of program of research looking at wellness and physician burnout. So just a quick overview, what is physician burnout? Well, burnout was first established maybe in the 1950s, and it was really an occupational syndrome. And it was thought to be predominantly amongst people that are delivering care. So really by people that are delivering care providers, but really it became understood later on that burnout in fact impacts a lot of people, whether they're in a caring profession or not. And there have been some concerns about what is the actual definition of burnout. Burnout is actually an ICD-11 code. It's in the DSM. It includes emotional exhaustion, where you feel like you're drained, emotionally drained at work. Depersonalization, people become more callous, more distanced from their work. And then a sense of low personal accomplishment where they really don't feel like they're making a big difference and they wonder, why am I continuing? And so the actual definition of burnout is still up for debate, but these are what the majority of people have settled on as the criteria for burnout. And then also we don't know things like, what is the natural history of burnout? Is it something that is a part of work? Does it naturally fluctuate? Does it improve? We don't know really any of these important aspects of what burnout is. We do know interesting things like burnout is contagious. So if one person has burnout at work, then the whole work unit can have burnout. And certainly through the pandemic, you often heard the phrase, the twin pandemic, and often people inserted another condition in the twin pandemic, but oftentimes people talked about healthcare burnout as another part of the pandemic. Burnout is a serious issue that I think we're all understanding now post-pandemic. You know, when I first started giving talks about the importance of burnout, I don't think it really crystallized about how big of an issue it was and how much it leads to things that are now commonplace, like human resource shortages, physician shortages. Now we hear a lot about the fact that we don't have enough primary care physicians, wait lists are long. Part of that is due to burnout, and I think that's become more of the forefront. And because the repercussions of burnout not only affect the individual physician with issues of decreased satisfaction, depression, suicide, but also impacts the organization, decreased work productivity, decreased engagement, and then also patients. Patients are less satisfied when they interact with healthcare providers that have burnout. And then also societal issues. The cost of the physician burnout in Canada alone is over 200 million because physicians have opted for early retirement or reduced clinical hours. Just to put this in perspective, you know, how did I go from researching cardiovascular disease to researching burnout? Well, at the beginning of the pandemic, I had a lot of people come up to me and tell me that they felt burned out, not just in my group, but all throughout the hospital. And then during the pandemic, we lost about 20% of our physician staff. So it had a huge ramification for us. And we've been trying to deal with the issues of how to recoup from that, but it has very real consequences. There are several theoretical models that underpin what we consider occupational burnout. And one I think that's important that came from the business school is this job demands resource model. And it really talks about this balance of sort of your demands, and they can be organizational. Oh, please go ahead and eat. Please go ahead and eat. They can be organizational, workload, quality of work, work stressors. They can be at a personal level, work-life conflict. If you have to do childcare while working, how that becomes difficult. Elder care, which some of us are experiencing, and how difficult that can be. And then the resources, sort of the positives in your bank, how you have professional collaborations, job crafting, your feelings that you're making a big difference, and also on personal level, what are your skills for coping? What is your social support? what is your health and finances? So all of these personal and occupational aspects come into play, and it's really just a balance of this. So the operational definition for burnout we used, and this is the Maslach Burnout Inventory, and about 80% of all clinical trials and all observational studies on burnout will use this. So I would say it's safe to say at this moment, it is the gold standard, although there are definitely limitations. And they have established cut points for burnout, but it's hard to imagine that if your emotional exhaustion is 28, you're burnt out, but if it's 26, you're not. So it's a continuum again, but there's an artificial cut point that we recognize. What we've known from burnout is that the higher the scores of burnout, the more severe it is. If you can reduce the scores, it does translate into improved physician wellness. So it's a 22-point scale. Also, what is the existing research on burnout? I've talked to you about how important it is, but what is actually shown in the research currently? So I really want to focus in on what intervention studies are there, because I think for decades we've known that there is burnout. The question is, how do we help? And this is on the minds of many different hospitals, individuals, health authorities, health organizations like Doctors of BC, the province, obviously, the National Canadian Medical Association, and all the other organizations that are interested in occupational burnout. But what are the things that actually make a difference? So if we look at this graph, it's really not meant for you to go through this meta-analysis, but there's a few that are showing slight promise, and one was coaching. So having physician coaches help you navigate through work and coping. And then the other was things like schedule change and workload shifting. But you can see that overall, with all the different interventions, they're really not making much of a difference. And even if you did look at coaching and schedule changes, there is a difference, but it's pretty small. And the authors concluded that the changes were actually not meaningful. So even though physician burnout and occupational burnout is so widespread, we don't really have a good way of trying to prevent it or reduce it. Interestingly, one thing that came up that might be of relevance is cannabis use was also associated with improvement, but nobody wants their physicians to be using cannabis, I'm pretty sure. So what are the challenges with research? Why is it that we've got a lot of studies looking at research, yet very little impact on effective interventions? And really, I think the heart of it is that physicians who are unwell and burnt out may not engage in research. So you automatically have a selection bias for whatever you're observing. Physicians typically have not been co-creators of the interventions. And that is true a lot for research in general. A lot of research is investigator initiated. And there's been, over the last 2 decades, a huge push to go to patient-driven types of research questions to improve meaningfulness of outcomes. There's a interesting statistic that during the pandemic, there were 22,000 clinical trials, and it was considered that very, very few of them actually were meaningful. Most of them were pilot studies. Most of them didn't even end up being completed. But it highlighted the amount of investment in clinical trials and interventions and research, and the fact that perhaps there's a ton of waste in research. So that was part of the WHO best practice guidelines for clinical trials, is to how do we make research more meaningful? And I think this dovetailed nicely also into this work on physician burnout. Rather than looking at investigator-initiated projects, how can we get ideas from people that are experiencing burnout, people that are in the trenches at work? And then the other thing is that most of the interventions relied on looking at individual physician behaviors, such as mindfulness and coaching, as opposed to organizational issues. And as I showed you from this model, the theoretical model, a significant amount of occupational burnout is related to organizations. And yet the vast majority of research does not even look at organization or organizational change. It's really been more on the person level. So this was really our opportunity. And this is the learning health system approach. And the learning health system approach is an expansion from pragmatic research. I think it's a great approach for the type of research that we wanted to do. So it is really the start of learning health systems research is the questions come organically from the people involved with the system, health system. So in our case, it was physician burnout. But you can see these are not investigator initiated. These are more organically arising from the people that are operating and working in the learning health system. And then it's more of the PDSA quality improvement cycles. So you have a problem, you collect data, try to use routinely collected data, you try an intervention, you evaluate the outcomes, and you keep going in cycles until you see significant improvement. And it's really working in collaboration with the health system and the research body. So it's really, truly a type of dynamic integrated knowledge translation. So what we did is we did a pragmatic approach, which is classically a mixed methods approach. We did survey, focus group discussions. And then we worked with the healthcare system, try to implement some of the things that we found. And then I will highlight some of those. So the first thing we did is we looked at the Department of Medicine. This is just at the beginning of the pandemic in 2020. We asked all these different groups from the Department of Medicine to respond to our survey. And our response went from 16% response rate to 85%. So some groups were highly responsive, and probably because it was such a big topic at that time. People were desperate, so people wanted something done. So it actually had reasonable response rates. And when we looked at the results by the low response rate groups, response proportion, and the high response proportion groups, there was really no difference. So we think it's probably representative. We had different age categories of healthcare providers, significant number of women, people that had children, different diversity in ethnicity, as well as LGBTQ. Sorry. Workload, most people who answered this survey were clinicians, but a significant proportion did research as well. So they're academic clinicians as well. And some physicians were working long hours, over 60 hours a week. And some were, again, like a lot of practice experience and then moderate practice experience. A lot of people worked, at least 10% of people worked at least 5 weekend days per month. So quite a few weekends per month. So we're able to get a good estimate. So this was actually the percentage of burnout. It worked out to an average of 67%, but you can see here, burnout is affecting every group. Yes, some groups more or less than others, but in general, it is significant in every single group. Statistically, we did not find any differences between these groups. We also analyzed for the groups that were looking after COVID patients that were not versus not looking after COVID patients. We didn't see really a difference in burnout, which surprised us, but it really speaks to how ubiquitous the effects of the pandemic were on different physician groups. We looked at the baseline characteristics that I showed you, and were any of these baseline characteristics associated with physician burnout? We also asked if participants felt overworked. And also an important question we asked was, have you quit or are you planning to quit? And so quitting was about 20% of people wanted to quit or had quit. And we didn't specify, what have you quit? Did you quit like a research project? Did you quit an administrative position? Did you leave the hospital? So we don't know quite what they were quitting, but they have an intention to step back from their work. So when we looked at person level factors, there really wasn't much that was associated with physician burnout. When we looked at work characteristics, when we look at burnout as a whole, there was not really that much that was associated with physician burnout. When we looked at concepts like you feeling overworked, like you don't have enough time you have a lot of work-life balance issues. We found that people that worked weekends and worked long clinical hours felt more of that overwork. Quitting, pandemic was an issue that was a big driver for people wanting to quit, but the work characteristics and the person characteristics were not so much associated with desire to quit. So how does that compare to physician burnout? As I mentioned, the parameters that we use to measure physician burnout are fairly commonly used. So we looked at studies that used identical cut points, identical research definitions that we did. But of course, it's difficult to compare one site versus another. But you can see here, our prevalence of burnout was 67% and about 61% in Canada. The USA was about 28%, and then after the pandemic, 63%. The UK, 32% before the pandemic, 63% afterwards. And the rest of the data showing is all pre-pandemic estimates. So you can see there was a significant hike in physician burnout during the pandemic and also locally. So then we did another cross-sectional survey, this time to almost 500 physicians at Providence Healthcare, asking very similar questions to see whether or not the issues of physician burnout affect all groups in the same way. So similarly, we had a good mix of different age groups, different sex, surgical, non-surgical, people that worked more than 60 hours, people that worked less than 40 hours. So we had a chance to look at a bunch of different parameters, and we found, again, that physician burnout was prevalent in all groups, surgical groups, non-surgical groups, the emergency department, outside of the emergency department. So really all groups were experiencing physician burnout. Again, no statistically significant differences. This is a prevalence of wanting to quit or recent quitting. You can see actually there is numerical differences, but because of the sample sizes, there was no statistical significant differences in this. But you can see numerically, maybe there are differences between groups. Again, we looked at multivariable analysis to see whether or not some of these factors were associated with burnout or intention to quit. And similarly, we saw the pandemic was a huge factor. And then for burnout here, we saw number of clinical hours was a significant factor, and then also weekends working. And this is the subscales of emotional exhaustion, depersonalization, and a low sense of personal accomplishment. So similar parameters, the pandemic was the largest factor. Then we asked people in those two sets of surveys, what do you think would help to improve burnout? What do you think are the important things that would help? And we really took all of the interventions that were already in existence, and we asked them to rate them on a scale of 0 to 10, where 10 is the highest importance. And we found, in fact, that almost all of the factors that were rated as highly important were generally regarding systems issues, organizational issues. So that included reducing non-physician work, and then reducing inefficient work processes as probably the two most highly rated interventions for promoting well-being. And so we also had a open questions and asked on the surveys, what are some of the strategies or issues? And so they, again, talked about some of these same issues like more efficient work processes and more transparency in physician roles, leadership, and aspects like that. So the difficulty with the surveys is that there was, I would say it's a low response rate of 42%, but that's not very far from average physician research surveys, but it does introduce selection bias. But again, as I mentioned, we analyzed high responder groups versus low responder groups and found no significant difference. And then we don't actually know what people were like before the pandemic. So is this worse? Is this better? it's unlikely to have been better, but we still don't know what was going on in Canada before this time. And then a high prevalence of burnout, but not many of the variables that we looked at actually were associated with burnout. So it made us wonder, do we really know what's driving it then? And so we then took this research and we presented it at different physician groups throughout the Providence Healthcare. This was a part of our integrated KT. And the hospital and health system and different health systems then came to us and said, okay, we see your research. Can we try to work on this? Because they knew that people were starting to leave, they were disengaged. So there was a real impetus to try to make changes. So even before publications could be done, even before studies, interventions could be tested, they were already now starting to be implemented. And I think this really speaks to the learning health systems approach, which is to gather data and then start with interventions in collaboration with the leadership and operations, and then continuing to evolve in that process. So we then started to do focus groups to find out what are those specific factors, because we really couldn't understand from the survey data what were the drivers. So we did with Dr. Amy Salmon and others, we did a qualitative research with semi-structured independent focus groups, interviews, and at this time over Zoom, so another pragmatic element. And then we did focus groups in GI, general internal medicine, emergency medicine. We also did focus groups in anesthesia. And as this work is evolving, we've done now cardiology, obstetrics, gynecology, and also radiology. And so we were able to ask them 3 simple questions. What makes you happy at work? What is a barrier to work? What's making you unhappy at work? And what can we do about it? So that's very simple questions. And then when we looked at the results, we saw that yes, some of the things that were barriers to feeling well at work were unique to the individual groups, but there was still a lot of overlap, which was important for us because it implies that maybe these are whole hospital interventions versus just targeted at the specific groups. And then what we saw was not different from what's been reported in the literature. We saw constant interruptions. Interdepartmental conflict was really important. So relational issues, heavy workload and scheduling, the sense of unfairness, feeling undervalued, unseen, that was an issue for work. Violence was an issue that physicians and nurses and other healthcare providers experience, especially in the emergency department. Waiting room medicine, which is where, and I didn't know this before, but many patients never leave the waiting room. They get almost all of their care delivered in the waiting room. They might come to the emergency room for an hour or two to talk to somebody, and then back in the waiting room. So I didn't realize that that was happening, but this is waiting room medicine. And some of the waiting rooms are not as monitored as the emergency department. I mean, you've all been to emergency waiting rooms, so you understand this phenomenon. And then for general internal medicine, a lot of things that were out of scope of practice. Either they were being asked to take on cases that were well above their scope of practice, where the physician felt very uncomfortable, like, am I looking after a surgical patient, but I have no surgical experience? A lot of moral distress with that. Or the opposite, I'm a highly trained obstetrician, but I'm doing a regular delivery, but I normally would work in sort of much more complicated obstetrical cases. So there was differences in what people were feeling as the types of work that they were getting. And they also noted an assembly line feeling. And this is true. All of this that I'm pointing out, I don't think is different in any other hospital in North America, or probably even the world. So I don't want to say this is unique to St. Paul's Hospital. It's really ubiquitous. This concept of assembly line medicine, it's this concept that we have to keep this rotation going. We have to check patients into the hospital and quickly get on top of things and discharge them. It's this constant pressure and cycle to admit and discharge. We don't want people waiting in the emergency department for a long time. So we're always trying to discharge patients. So patients feel that we might be rushing them out the door. Physicians and healthcare providers, nurses, operations staff don't like that feeling, but they obviously have a lot of patients waiting in the emergency department. So it's this sort of treadmill or assembly line of getting people in and out, in and out, in and out. And when that happens, suddenly interactions become more transactional. So this is what we found from the focus groups. These are some quotes. I won't actually go into the quotes, but we got a lot of rich data, and interdepartmental conflict was a significant issue. Just arguments between groups over who's going to do what. So there's a lot of role ambiguity. If I'm a surgeon, do I take a non-operative case? If I'm not a surgeon, do I take a case that a surgeon, it's in the surgeon's scope of practice, even though it's non-operative? All of these kinds of issues created a lot of conflict. Key themes emerged, and this is including the research that we've done now with the additional 3 groups. Conflicts was a major issue. And the reason why there's conflicts, it's not because it's a personality issue with the different people in the healthcare system. It's because of the way the system is. For example, if there is not enough OR space and one physician group has an emergency case and it bumps another surgeon's case, then that surgeon is sitting doing nothing that day. That patient is angry and upset. Maybe that patient's health condition gets worse. So that's the natural response, is to have some conflict when resources are constrained. There's only so many physicians to admit patients, and there's a never-ending, maybe onslaught isn't the right word, but never-ending demand of patients, and aren't enough actual physicians to see all the patients. So that naturally you can imagine how conflicts can arise. So that was a huge issue. And then high workload. During the pandemic, we did an informal survey and found our workload actually in our group increased by 25%. The EMR, so Cerner, I'm sure you probably heard about challenges with Cerner. Non-physician work, a lot of paperwork. I will say they could never make a TV series about the actual physician work, because it would just be a lot of people in front of a computer typing, and nobody would want to watch that. And then other things like equipment inadequacies, the physical environment, which hopefully when we go to the new St. Paul's Hospital will all be new. Perceived lack of unfairness. And this is something that probably permeates throughout all occupational places. This lack that some people, there are haves and have-nots. So we saw this as well. So again, the operational leadership at the hospital was very keen on all of this data that we found, and we're very keen to try to implement, to try to improve lives for physicians. So then they knew that we were getting all of these results actually from the physicians. So I talked about getting meaningful research, asking meaningful questions and meaningful interventions. So this was actually taking physicians, what was getting at them, and trying to establish interventions for them. And we worked in collaboration with the hospital and tried to undertake more pragmatic research. And just to highlight again, they're real world settings, they're inclusive populations, interventions are flexible. So treatments are applied as they would be in regular practice rather than as a strictly controlled protocol. You can imagine during the pandemic that there were so many things going on. There were so many interventions to try to improve people's mood, anxiety, depression. I mean, it was everywhere. And people were doing their own things. The work environment was also doing many things. And then superimposed on that, we were doing this approach where we were trying to use the systems issues identified by the physicians and try to work with operations to work on these systems issues. So comparative effectiveness, often compares new treatments with standard of care rather than placebo. The standard of care, unfortunately, for this research was ever changing. Every week, it was a different intervention that was in the background operating, and minimal research burden. So data collection is embedded within routine clinical care to reduce disruption. So when we distilled all of the issues that each group had, we came up with this kind of a dashboard. So we had what was the intervention, we had worked with the physicians, worked with the operations leaders, discussed what would be an appropriate solution, agreed upon solution, and then we assigned it to somebody, and then they worked on it. And then we tried to see if we could get these completed, if we can get these not completed, if they were in progress, where we were. So we kind of kept this dashboard going of what these interventions were. And I imagine that each one of these could have been its own clinical trial, but we didn't do it that way. We had 8 massive, sometimes small, sometimes massive interventions that were being employed. But the intervention was actually the approach, taking what physicians were saying and trying to work on them in a collaborative way with leadership. So this, for example, was one. So one was a Cerner issue, can't find what I need. I'm spending 20 minutes to find what order I need, and it's wasting my time. It's making me frustrated. So they created, Dr. Janet Simons created this Cerner lookup sandbox. So it was an online tool that you could just plug in whatever the lay term was, and it would tell you what was the Cerner order to find. So it was a shortcut to finding the codes that you were looking for. Admissions dispute. This issue that I told you about, the conflicts, when I came here 20 plus years ago, this was still an issue. So this tells you, and probably the 20 years before that, it was an issue, and probably 20 years from now, it'll still be an issue. But this admission disposition dispute, we pulled data for this, piloted data, brought it to the attention of the hospital. They took this very seriously. They developed a task force that worked on this. And I'm really pleased to say that the entire hospital, Dr. Palapu, many others, Dr. Ko, pushed this across the board, Dr. Ramani, and created for the first time a disposition algorithm and an approach to disputes. So the first time, honestly, in 20 years, we had something that can actually help with the conflicts. So instead of having a fight or an argument, you just agree to disagree and then send it to somebody else so you don't have to get engaged in the fight. And there's also an algorithm that nicely outlines what problems go to which groups. So much more improvement in role ambiguity. So I think that this was really quite promising. And like I said, some of these issues had been on the plate for the operations leaders, but doing this process helped highlight what were the important prioritized interventions for them to work on. So it, in fact, was a catalyst. So then, as I told you before, we had done a survey on burnout. We didn't have individual data, we had group level data. And then all of these initiatives started happening. And like I said, the hospital really did an amazing job to try to work with us and work on all of these initiatives to the best that we could. And then we did another burnout survey. And this time we asked more questions like, did all the things that we do, did we actually make a change? Did you notice the change? Because this is what you asked us to change. And then did that change translate to a change in wellness? And then did it overall improve burnout? So we had our groups, GIM at St. Paul's Hospital and the emergency department at St. Paul's Hospital. And we did the interventions with those groups, the whole hospital interventions, and targeting these two groups. And then we had another group at a different hospital at VGH who also was not going through the same process, but we also had pre and post survey data on. And having said all this, in the background, people are working on their personal wellness. All the hospital, the departments, the divisions were also working on interventions to improve wellness. So that was already embedded. You could say it was noise in the clinical trial, but it actually was was part of that pragmatic usual care. So we did exit surveys. So this is the follow-up. We had some groups with reasonable response rates, but not high response rates in all groups. So this actually shows you what did physicians do during the pandemic to improve their wellness. So almost over 40% of them had reduced their clinical work. They had stepped back. Some of them changed hospitals, moved out of hospitals. As I mentioned, 20% of our physicians left and retired. Many of them reduced non-clinical work. So if they were potentially engaged in research or they were engaged in administrative work, they did not, they stepped away from those things. A lot of people did personal wellness, the majority of people, and then a lot of groups did work wellness. Those are interventions that were set up by the work environment. Some people were involved in systems change. So the idea behind that was that if you were involved in a process of systems change, then you would feel more engaged, have more meaning with your work, and that might help with preventing burnout. And then systems work that is directly with patients, so directly work that improves patient care. Working on your own career and leadership messages. We frequently got messages from leadership, which were motivational messaging, appreciative messaging. So some people acknowledge that, even though it actually was sent to everyone. Only, around 10% of people felt that that was part of the wellness that they received. And then at one place developed a new quiet space. Essentially, when we looked also at those who perceived their wellness improved versus those who didn't, you could see some things like personal wellness made a difference, was associated with a difference. Reduced clinical work, also wellness was people felt that those who said that they reduced their clinical work were more likely to say that their wellness had improved. But you can see for many things, not much of a difference between what you did and how you felt it impacted you. And then we looked at objective measures. I know you said your wellness was improved, but did you actually score on burnout or no burnout? And we saw that people that had burnout reduced clinical work. It's not a causative study, so we can't say, because you were burnt out, you reduced clinical work, or did the reduction in clinical work make you feel burned out? Reduced non-clinical work, same thing. People who reduced non-clinical work were also more likely to have burnout. We looked at what are all these factors with the respondents' sense that they've improved in their wellness. So they said reducing clinical work really helped. That was associated with improvement in wellness. Not really systems change, even though systems change was rated the most important factor for improving wellness. Leadership messages was not associated with improving wellness, even though people said that they felt leadership wasn't appreciative enough. Personal wellness, it was not statistically significant. Work wellness also not statistically significant. Same thing with activities associated with burnout and not burnout. So going back to the interventions that we did. So these were, for example, what we did in general internal medicine. Some things were easy and we definitely fixed, like providing more computers, providing dedicated spaces, and some were difficult, like admissions dispute that I told you that we did eventually work on, but at the time of the exit survey, it was not finished. Many of these interventions were very difficult to do. Some were super simple, but some were very difficult and would take years to accomplish. Many of these things, in fact, today have been accomplished. Same with the emergency department. Broken or missing equipment, they started a new QI project. where they were so frustrated that when they needed something in an emergency, they would open the drawer and it wouldn't be there. And then they would run around the emergency department trying to look for things. So they were able to do a QI project where now that they have an ongoing quality improvement where they always have equipment at the ready. There's been a lot of work done on reducing violence. You probably noticed all of the interventions that are done to improve violence. The physicians were portering patients. I think that is still was not funded. The admission dispute issue was a huge issue because the emergency department was often caught in the middle. That was worked on, and significant changes, policy changes were created. And so you can see that many things happen. And then when we looked at the actual interventions, I've broken it up into at the time, the blue was what we 100% fixed. How many people felt that this stuff was fixed? Only 20% of people noticed that this was fixed. And then if you noticed it was fixed, did it improve wellness? Yes. The waiting room medicine I talked to you about wasn't fixed. It did not lead to no one noticed because there was no improvement. What did the impact of no improvement have? 61% of people said it worsened their burnout by having nothing change. Admission disputes, only 10% of people noticed that there was a new policy. And 10% said of the people that noticed it improved, they said that they felt better. But of the majority of people that didn't notice it improved, they said they felt worse. So what about objectively looking at burnout? So when we actually looked at burnout, this is the numerical difference. You can see the percentage of burnout in the GIM group where we did the admission dispute changes. There was a significant reduction in burnout. In the emergency department, where we also did the intervention, there was a significant increase in burnout. In the GIM VGH group, it was very little change. We did not do this intervention in that group. When we look at multivariable analysis without adjustment, you can see that there was nothing that was statistically significant, but there is a signal, a non-statistical signal, as this is a pilot, that maybe there is a benefit of the systems change. So just to close, this was a pilot study. This latter part was a pilot study. The data suggests that physicians do use a variety of strategies to improve wellness, and they had very varying impacts on wellness. Reducing clinical work wellness activities, and personal wellness were actually associated with more likely reporting that you felt better. Systems change that we did in our pilot. It ranged from something that was minor to major, complex, and challenging. Many were difficult or took a long period of time to actually make an impact and a change. Most physicians didn't even though we made the changes, didn't notice it, didn't register that these improvements had actually occurred, even though some of them were night and day, 100% improved. Improved systems changes were associated with improved wellness. So if the physician noticed that something had improved, that made them feel a lot better. If they noticed it didn't change, they felt worse. Overall systems change approach versus usual approach had no significant effect on physician burnout, statistically speaking, but I think given this is a pilot, it has a signal that it might be beneficial. Now, low engagement is an issue for all burnout studies. There was poor adherence to interventions, and that is very typical for some pragmatic studies, but it made it hard to make any firm conclusions. Interventions were changing at different paces. There was a lot of external confounders. There was a lot of, were they background noise with all the other interventions that people were doing at home, at work, or was this significant and it made some of the results appear non-significant? Balancing the need for real-world applicability with robust research methods. I think that this pilot study was more pragmatic than evaluative. And so I think the research rigor probably could have been improved. in terms of more adherence to the interventions. Moving forward, we still want to continue to evaluate systems, maybe single systems change rather than taking on so many, something with a shorter, more realistic intervention time, and then again, evaluate processes of change, but probably more rapidly to see if there's been an improvement. So probably more shorter and more rapid cycles rather than long periods of observation and intervention change. We need to continue learning health system cycle. This was a real example of how in real time, as the data is coming out, the research is being implemented in a real health system. So thank you very much. I want to also thank, we received funding for this work from multiple sources, Providence Healthcare, and more recently, Doctors of BC. And then want to thank Farhad Ghassaminejad, who is our medical student who did a lot of the survey and qualitative reviews. And I would like to thank Anita Palapu, Peter Dodick, Amy Salmon, Deanne Lakai, Lawrence Chow, Debbie Rosenbaum, Kira Rich, Amelia Rids, Vishal Varshni, and Elizabeth Stanger. Thank you.